So this is a talk that I also gave last year. So if people who are present from last year, I can see some of them here. I can ask questions. I hope I have only 10 minutes, so I don't have much time. Let's see. So definition: scoliosis, kyphosis. It's simple. Obviously, it's a three-dimensional deformity. A sagittal coronal rotation when we're talking about scoliosis, whereas kyphosis, it's single sagittal plane deformity. So we know this, and it's important to understand the difference between the two. And the scoliosis is never single plane. There's always something else happening. I'm not going to go into the history. Ideal alignment, which allows a standing posture with minimal muscular energy expenditure. So when you're standing, you're not putting too much pressure of any of the muscles. That's the ideal alignment. This is accomplished through a complex relationship that's curvature of the spine, the morphology of the pelvis, and the musculature of axial and appendicular skeleton. Current parameters allow us to a certain degree to look at alignment or malalignment, and then depending on that, we know patients' symptoms and health vary. So organization of spine and successive curvature in the sagittal plane is crucial to make us stand up vertical. And we are typically, the specific thing for us that we are the only one who can do this completely. And there's only vertebra to have a lordotic lumbar curvature. And because of that, we are able to stand up without any problem causing any problems to pain. Cone of economy is important to understand. And spinopelvic balance in the sagittal plane is an open linear chain linking the head to pelvis. So it's all the way from top to bottom. And if you're going to stay in this cone, then obviously you're not going to put pressure on any of the muscles. But if you go outside this cone, then you cause problems to yourself. So it's important to understand that. This is important. So when you're taking pictures, many people ask me, how do we take correct pictures? You don't need to have a large film cassettes or anything, as long as you get a real size image. If you get a real size image, tell your technician, take a big chest x-ray picture, and you can attach three together, and it works pretty well. So you've got standing PA, supine, side benders, either one side or the other. You've got standing lateral radiographs. The important bit with lateral radiographs is that elbow and wrist should be fully flexed and hands in a fist, and the proximal and phalangeal joint all the way into the supraclavicular fossa. So it's important. No external support should be applied at that time. Hyperextension films could be taken when you want to see how much of a deformity would reduce. Okay, we have just done this and we will revise this. Echo just went through these. So basically for dummies, if you look at it, so A is for thoracic kyphosis, C is for lumbar lordosis, SV is sagittal vertical axis. So it's basically talking about an axis that starts from a point C7 all the way down and going through the anterior tip of the sacrum. And then we have TPA and proximal thoracic slope. So these are the two. And you can see it's T1, to pelvis, and also we've got a sagittal plane going down. So all of these vary and matter eventually when you're deciding what kind of surgery you're going to provide. Will you provide a surgery? Will you improve the balance, or are you going to do that with the help of some kind of exercise or something else? Pelvic parameters are important. Again, ECO has just gone through that. The way to remember, simple, is sacral slope is what it is. So it's actually the slope of the sacrum. So there is nothing fancy or difficult about it. And that's the angle that's taken between the slope of the sacrum, the top, and you've got this horizontal plane. For pelvic incidence, we are looking at the pelvis itself, and it's very, very important. Pelvic incidence, obviously, you take the head of the femur and goes to the middle of the sacrum, and you join a line that's going vertical, and this is so we are looking at pelvis. So pelvis is what you're looking at, so these two things must come in. The tilt of the pelvis, again, then goes differently, because what happens is that we take, instead of this line, this going in the same line, but instead of this line joining there, it's depending on their vertical line. So you take a straight vertical line from the head of the femur, the middle of that, and then a line from the middle of this, and whatever is the pelvic incidence. And there are 2-3 important things to remember from this perspective, and I'll come back to that. So sagittal balance we are talking about, so we can take either a C7 or C2 body midpoint. and we take that to the posterior superior corner of the sacrum, so bring it all the way down to that corner. And once you do that, you get your sagittal balance line. And that's basically a plumb line that's coming down. And if it's within 3 centimeters of the sacral promontory, it's supposed to be within normal limit. But obviously, it varies depending on age, other factors as well, and you need to consider that when you come to it. So if you've got your neck, which is bent down, then pelvis is going to automatically change its posture as well. So there are positives and negatives, and obviously when you go towards the right, you become negative, and you go towards the left, you become positive. So it's depending on where we are going there. So C2, C7, SVA. So again, we take a point from the plumb line coming down from C2 dens all the way down to the center of C7. And this is a cervical spine specific sagittal alignment that we're looking at. And there are 2-3 parameters you need to look at. And this is very, very simple. So C2 plumb line and SVA C2 to 7. So this is the angle that's differentiate between when you take the C7 plumb line and the distance between the two. It's important to remember that as well. So when you're looking at specific cervical spine deformity, these angles are important. C2, C7 angle, and this is typical Cobb angle that we now measure. T1 slope is important. It's been shown to be significant, and it's important, and you need to try to reduce it if at all possible. And C2, T1 pelvic angle, CTPA. So basically what we do is you take a line from the center of C2 vertebra all the way down to the coxofemoral axis. So this comes all the way down, and you take another line from the T1, and again, join that together. And then you take the TPA is the angle that gets formed when you have got the same line coming down. So this TPA and the CTPA. So these two lines are important, but it's important to understand that they obviously vary from patient to patient. And as long as you're continuing to measure them, then and see them in your patients, then you should be able to pick all the problems that are associated with it. So simple concept that when you've got your TPA, which is worse. So TPA is, again, we talked about the line going from the top of the sacrum, and it's C7 plumb line and T1 plumb line. And if you do that, then obviously this angle increased will cause more problems. So as long as you're going down and down and down, then your muscles are going to be working more, you're going to have more pain, and all that is important. So I think you don't have to remember all these lines, but every time you see a case which has got deformity, if you go through them, it will be easy for you. This is simple, so any line that's from the middle of the sacrum going up, so that's CSVL. And so pelvic parameters, again, these 3 things, if at all anything you need to remember. If you remember pelvic parameters, then majority of your deformity issues will be solved. So pelvic tilt, I'm going to go again. So angle between sacral slope, so in the middle of the sacrum, and it's coming down to the biconvex femoral head axis. And if you take a straight vertical line, so that's the tilt of the pelvis. How much of pelvis is being tilted? So if the pelvis goes down, this changes. So they both changes simultaneously. Sacral slope, we have already talked about. It's very simple. There's nothing to it. Incidence this is the angle when you take a perpendicular line coming down like that to the sacral plate of the midpoint. So if you come down like that, and at the same time you have a line connecting these points to the femoral axis, and this incidence is the pelvic incidence. And we know that if you take pelvic incidence, so that pelvic incidence is equal to pelvic tilt and sacral slope. So they will, or you add these two keep changing. Pelvic incidence is obviously is the one which remains static. So depending on your deformity, and I think we have, owner has got a very nice slide to follow in the next session that he's giving. So the more tilt you're going to have, the more problems you're going to have, because in order to maintain neutrality, you people go down, and this is important to understand. So degree of pelvic retroversion is essential in understanding the severity of sagittal imbalance and plays a key role in determining the role of surgical correction. These are some of the parameters that we generally take, but the important thing to remember is these parameters change, especially in old age. So these parameters, we don't have to think about correcting to these levels in old age, because we try to do that, if you overcorrect, you will cause more problems than benefit. I'm not going to go further because I would like owner to take up from here, and be giving him another 10 minutes extra just to go through the evaluation of a patient who comes in with spinal deformity. Owner, please.